Hello, good afternoon, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant, welcome you to this webinar on Carbetocin in action. Doctor, at Hetero Healthcare, we have got 25 years of excellence, 36 state-of-art manufacturing facilities, 300 plus products in portfolio. We have got presence in 126 plus countries, to 25,000, 21,000 employees globally. We are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving for fulfill unmet healthcare needs. We reach out to customers across India with wide range of products encompassing multiple specialties. We are pioneering in quality and innovation. We have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's webinar, Carbetocin in action, case studies from labor. Doctors, you'll agree with me. Well, Carbetocin, we all know that is used for prophylactic management of postpartum hemorrhage. PPH is a condition which is best to be discussed and best to be read rather than to be seen. Because, and of course, expect unexpected, every patient has got a potential to land in PPH. Although there are many papers and many documents justifying the role of Carbetocin in PPH, we would always like to have our own expert speak about their own experience and share their own experience about use of Carbetocin. For which today you have got Dr. Srujana Siddhani. Welcome, madam, to share her experience. Welcome, madam.
Thank you so much. Thank you.
Dr. Srujana Siddhani, madam is consultant obstetrician, infertility specialist and laparoscopic surgeon at KIMS Cuddle, Secunderabad, MBBS from Gandhi Medical College, Hyderabad, DGO from Osmania Medical College, MRCOG from Royal College of Obstetrics and Gynecology. Madam has attended multiple workshops, conferences, and both at national and international level, ESHRE from Europe, ASRM from US. But the skills of madam include preconceptional counseling, high-risk pregnancy care and delivery, recurrent pregnancy loss management, prenatal diagnosis, including performing amniocentesis. Welcome once again, madam. Over to you.
Thank you so much. Thank you for the introduction. Yes. Can we decrease the size of the slide? Then give you the whole slide.
What I should do?
Decrease the size of the slide. Can I do that?
I mean, this goes in the presentation mode, no? So the slide is big. Jayat, how do I reduce?
Half of it is seen actually.
It cannot be
Fine.
seen.
Hello.
Yes. Hello. Yes, now I can see, but
Now I
a
can
part
see.
of it is missing actually. That's fine. Yeah. Okay, no
Yes.
problem.
Okay.
Yeah, sure. We'll go ahead with the discussion of the overall presentation.
Yeah.
Then the first, obviously, we all know that what is PPH, and then every obstetrician, PPH is every obstetrician's nightmare, I can say. So every obstetrician prays that she would not encounter any PPH, but it is in a routine obstetric practice. It is especially those who are dealing with the high risk cases and in tertiary and centers. PPH is a common scenario. Coming to the definition, PPH is a loss of at least 500 ml of blood following vaginal delivery or 1 liter following cesarean section. And most of the times we can anticipate a PPH because in high risk women where there are certain risk factors like obesity, twin gestation, polyhydramnios, big baby, any other risk factors, we can anticipate PPH. But sometimes we will not be able to anticipate PPH. So it can happen in a normal woman who doesn't have any risk factor at all. So one needs to be totally equipped and vigilant to prevent PPH as well as treat if they encounter even in low risk settings also. So PPH is a leading cause of maternal mortality in low-income countries, especially. It also causes, there are reported deaths even in the developed countries, but it is more common in the developing countries like India, because we know that many additional risk factors which can cause PPH are there in our women. Majorly, anemia is a major risk factor, which contributes to a lot of maternal bleeding and maternal mortality in our country, and is primary cause of nearly a quarter of all the maternal deaths. So coming to the numbers, so obviously the leading cause of maternal mortality is this PPH, or the maternal bleeding, which is about 35% contributing all maternal deaths across the world. When it comes to developed countries, it is slightly less, like 16 to 20%, or it can be as high as 240 for 1 lakh live births. The MMR can be as high as that in developing countries and in low income countries. The recent reports of India show that it is around 97 per 1 lakh, according to the 1820 census. See, the global incidence is 14 million suffer from PPH, and the incidence is, it can vary from 1 to 10% following delivery. It is around 2 to 2% following vaginal delivery, and as high as 6% after cesarean section. And when it comes to Indian scenario, 38% of the maternal deaths are directly linked to PPH. And yes, so 25% of the global deaths take place in India, being this is being a highly populated country, and two-thirds of the maternal deaths are directly attributed to PPH, which most of the times can be preventable with adequate precaution, proper methods to prevent the PPH, and adequate action. So India has unexpectedly high maternal mortality rates. Definitely, they have come down in the recent past, but there's a long way to go to bring down the this mortality, with relation to the blood loss, especially in the low resource settings, and then where the blood bank facilities are not available, and in remote areas as well. Yes, next, please. So, as obstetricians, everybody is aware of the reasons for the postpartum hemorrhage. It can be the atonic PPH is the major cause, and the other causes, like thrombin coagulation failure, or traumatic PPH, it can be should be ruled out. And of course, tissue like the presentation, the retention of placenta, as well as abnormal placentation. All these are the major causes we are all aware of. Next, please. See, when it comes to the dealing with PPH, early identification and prompt action can avert a lot, avert major complications, especially maternal deaths. So it's important to initially be aware of the clinical findings and then the symptoms of the blood loss. When if the identification happens in the initial stages, when the deterioration can be prevented, and the deterioration can happen, the mild to moderate and severe PPH can occur sometimes in a matter of minutes also. So high vigilance and prompt action is needed. So one has to assess the clinical condition, as well as they examine the patient. The investigation as well as the treatment has to go hand in hand, because time is extremely important in these cases. So obviously, abdominal tenderness, or any other features of any collapse, or increasing abdominal girth, loss of contraction, which can happen in uterine rupture, tachycardia, vaginal bleeding. These has to be taken seriously. And of course, we know the how to assess the clinical condition, and mm, categorize it into mild, moderate, and severe PPH. So these are the different, the clinical parameters to assess that stage. We are all aware of that. Next, please. Yes, the initial evaluation, as I said, rapid assessment of the patient status, and any tachycardia and hypertension, and assessment of the blood loss should be done. And also the examination should go hand in hand. They should assess the entire genital tract for lacerations, hematomas, and especially the traumatic PPH needs to be ruled out. And rare causes like uterine rupture also needs to be ruled out. In the examination, and manual examination for the retained placenta. And of course, we have to, in centers where the ultrasound is available, we have to make use of it to make a quick assessment, to check for any intraperitoneal hemorrhage in case of uterine rupture and also any retained placenta. And rarer causes like uterine inversion also be needs to be considered. And of course, while stabilizing the patient, the laboratory investigations to assess the loss of the blood, the hemoglobin and hematocrit, and of course coagulation parameters, all these also be needs to be done rapidly. Next, please. So, depending upon the cause of the postpartum hemorrhage, we know that it needs to be dealt. In case of uterine tone, obviously, the along with the investigations, you need to use uterotonics, especially the oxytocics. Then comes the prostaglandins and got alkaloids, one after the other. And of course, if the medical methods play, then we can go to the mechanical methods as well, like uterine tamponade. And we use everybody has a protocol to how to deal with the PPH, so especially the atonic PPH. And of course, if you identify any tears and trauma, immediate uh, address of that, that means the suturing and identification, and maybe the shift to the operation theater and arrangement of the blood, everything needs to be done uh, hand in hand. Of course, any catastrophic events like uterine rupture or extension of the angles, especially tears during the cesarean section, needs to be identified and immediately addressed. And other rare causes like liver rupture, all these may also be to be kept in mind. And the management, of course, depends upon the cause. And if the retained tissue like retained placenta, then examination under anesthesia and manual removal of the placenta has to be arranged as soon as possible if the bleeding is catastrophic sometimes. And of course, coagulation, we need to arrange for the blood and blood products. And so these are how attempts should be made to identify the cause, and depending upon the cause, in parallel to the resuscitation, everything needs to be done to um, prevent the maternal death. Next, please. So obviously, what is the rationale for development of carbetocin in a new heat stable formulation? Carbetocin is available in room temperature stable formulation and convenient while presentation. So now, as this is available in a room temperature stable formulation, um, so a lot of disadvantages of the previous formulation, as well as the other other uterotonics where they need refrigeration to avoid degradation, especially the oxytocin and the ergot alkaloids can be served. That means in settings where this cold chain maintenance is not possible, this can be very useful. They, because of the heat stable formulation, is of oxytocin is not currently available, and that sometimes the improper storage can make the drug inefficient, and then in spite of all the efforts, a lot of loss can happen. So we need to be really um, uh, we need to be very cautious regarding the cold chain maintenance of the other electrotonics. And also the previous formulations of carbetocin should be stored, again, they need refrigeration. Now we have a stable formulation where it can be just left at the room temperature, and also they have better shelf life, and which is a stable at room temperature, better shelf life of 24 months. And then, of course, in humid and tropical countries like ours, this is really helpful. So it can be stored at 30 degrees with 75% humidity, and that needs, again, that avoids need for cold chain storage and other logistics. It can be avoided. So, and it is provided in a vial form, which is good. Next, please. So we are aware when the uterotonic needs to be given, and there are different types of administration. But most of us obviously follow the crowning of the baby's head, or delivery of the anterior shoulder, and of the second stage of following delivery. Most of us follow the after the delivery of the anterior shoulder, is a better time, and most of the clinicians follow this routinely in their practice. And of course, for the prophylactic use, the prevention of PPH and active management of the third stage labor, and of course, the management of PPH, we use uterotonics. On the basically the common uterotonics we use are the oxytocin, then comes the carbetocin, egometrin, sintometrin, which is a combination of egometrin and oxytocin. and misoprostol and carboprost. These are the different molecules used as heterotonic agents. Next, please. Yes. We know that regarding the carbetocin, it is a synthetic and it's a oxytocin agonist. So it's a synthetic and long-acting analog of oxytocin. So it is used for the prevention of PPH. It is a uterotonic used for the prevention of PPH, especially only uterine atony. And see, it comes in a vial form where 1 ml of solution is equal to 100 micrograms of carbetocin. And this was created for making after making several modifications to the oxytocin structure to prolong its half-life and decrease the enzymatic degradation, so it acts for a long time. Next, please. Yes, there are many different trials to support this the use of oxytocin and show that it is as good as oxytocin, and then carbetocin that is as good as oxytocin and is not inferior to oxytocin, especially the WHO champion trial, where it's a randomized double-blinded randomized trial where 30,000 women across 10 countries, which includes India, are also studied. So this trial is conducted by the WHO Department of Reproductive and Health Research. So it concludes that the carbetocin is as effective as oxytocin for the prevention of PPH. Next, please. Yes. So this is the trial, the comparison between the carbetocin and the oxytocin molecule. So this the results of blood loss of more than 500 ml, more than 1000 ml, or at least one unanticipated adverse events and one serious adverse events are almost comparable to each other. So the frequency of blood loss of at least 500 ml or use of additional heterotonic agents with carbetocin was proven to be non-inferior to oxytocin. So the use of additional heterotonic agents, other interventions to stop bleeding, and adverse effects did not significantly differ between these two groups. So the carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or use of additional heterotonic agents. This trial concludes that carbetocin is non-inferior to this. And also the Cochrane reviews. Next, please. Yeah. Cochrane review data from 11 studies involving 2,000 odd women shows that for women who undergo cesarean section, carbetocin resulted in statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to sintometryl in the prevention of PPH for women who have vaginal deliveries, and is associated with significantly fewer side effects. So this is a strong recommendation, because the Cochrane review with 11 studies obviously is a strong recommendation. Next, please. Next, please. Yeah. So different guidelines, that is we have the WHO, the Canadian guidelines, and the RANSCOG, the New Zealand guidelines, and FIGO, and the other authoritative guidelines mention the use of oxytocin for the PPH prophylaxis. So even the WHO also one of the following among the list of puts this among the list of the uterotonics for the PPH prevention. And the Canadian guidelines also say that IV bolus of carbetocin as the PPH prophylaxis, and FIGO also recommends the use of carbetocin for prevention of PPH. Next, please. Yes, regarding my experience with carbetocin, I have been using carbetocin since a long time. The maybe around 4 to 5 years from now, I've been using that, and I've been usually routinely using it for my. I have totally shifted to carbetocin, routinely using for prophylaxis, especially in the cesarean sections. Uh, always I go with carbetocin. So next, I have, of course, we deal with being at a tertiary center. We deal with a lot of high risk patients. I have lot many experiences in dealing with the high risk women for PPH and carbetocin usage.
Madam, now you have used this for almost 5, 6 years, and most of the time you must be using IV.
This like last 2, 3 years, I've been using it only mostly IV actually.
IV. And how was your experience? I mean, you said that it worked well. Did you require any additional uterotonics?
Sometimes I required
Sometimes,
it
yeah.
where we had very extremely high risk women
Yeah, 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 yeah. And
post cardiac arrest.
no drug would work 100% in all the patient.
Yes, yes, definitely. But one of our residents also has done a thesis where to see the effectiveness of carbetocin and non-requirement of other additional uterotonics.
Okay.
So it is as good as any other thing, and the requirement for additional.
You sometimes becomes inaudible, madam. We cannot
Yes,
hear you.
yeah. So,
Uh,
yeah, our being a tertiary hospital, we use it very regularly, and
correct, correct, correct.
the requirement for additional uterotonics is there in some patients, but it
Yeah,
is comparably less when we use
correct,
a.
correct.
Yeah.
Any major side effect you experience with this?
The side effects profile is also very less actually.
Yes.
The hemodynamic safety profile when compared to other drugs and the the complaints from the patients are almost very less when compared to the other drugs, as I feel, because we've been giving routinely for
Correct.
the past so many years, and the side effects, as we observe, are very less actually. In fact, rare.
So we come to the questions. And first question, I already answered your experience on using
Yes,
carbetocin.
yes,
Now, which is, although, in our practice, we can see every patient is likely to land in PPH. But what is generally a patient profile where doctors can anticipate high risk patient, that is, who can land up in PPH potentially?
yes. We have like the anemia is the major most important
Correct.
cause.
In our country, yes.
Yes, yes, of course. So the we obviously you know mm, take anemia very seriously, and
Yeah, yeah,
we
yeah.
aggressively correct anemia whenever we
Correct,
encounter a patient in
correct,
pregnancy, because that is the most important factor to prevent this PPH. So in spite of that, being a tertiary care center, we see women even who are severely anemic or moderately anemic at the time of delivery.
correct.
So those are the patients who can land up in PPH. So, of course, with all the apart from the prophylactic uterotonics, we take all the precautions to keep the blood ready and everything, to prevent PPH in such patients. And of course, the other being regularly delivered twin gestations, IVF, elderly
Yes,
prime,
yes, yes.
polyhydramnios, obese patients, extremely morbidly obese patients. These are the women who can land up in PPH.
Can diabetes or hypertension predispose a patient to PPH?
Yes, yes, of course. They do also predispose the patient to PPH
PPH.
most of the times because they have big babies,
Correct,
and this is
correct,
one of
correct,
the reasons how they indirectly contribute to the PPH again.
correct, correct. When would you actually prefer carbetocin over oxytocin for prevention of PPH?
So, especially in cesarean sections where we
Okay.
don't use any uterotonic, we directly use carbetocin, without most likely oxytocin. At least in the last few years, we've been doing that. But in case where we have been the laboring patients, where we use regular oxytocin for augmentation, and of course, up till delivery,
Yeah,
there we continue to use the oxytocin.
oxytocin.
Yes,
So essentially, when you don't use oxytocin for augmentation, you'll use carbetocin, like in cesarean section.
absolutely. We definitely use that.
Can we use carbetocin in case of retained placenta?
Yes, there are some conflicting, some say, opinions where
Yes, yes.
there's slightly increased risk of retained placenta. As per us, we didn't much encounter that actually. So now I think now we know that it can also be used in that cases as well.
Listen.
So yes,
And this is another important question. RH negative mothers.
yes, we've been using even carbetocin for Rh negative mothers also.
And here, incidence of PPH could land in further trouble because the getting of blood would be still more difficult, RH negative.
We've been using Rh negative also. There's no as of now we didn't.
Can a doctor use carbetocin for prevention of PPH if oxytocin is used for induction?
For induction, maybe yes, but we have been using that for augmentation and up till delivery. Then the receptors may get exhausted, and then the
Yeah,
carbetocin may not be of much use. That is where we still continue to use oxytocin.
But then short life of, I mean, oxytocin has got a short half-life. So
Yes,
would the effect
for
be,
yeah, only when induction it is used and it is not used any further, then maybe we can consider obviously carbetocin.
BPH?
But
Yeah.
yes, yeah.
I mean, again, you have been using IV, but is there any scope for IM route?
Um, yes, as
I
now
mean, this
trust.
could be more important in the interiors where there may not be additional nursing staff or additional help in the periphery. I mean, this could be a little more relevant for those
Yes,
type
that
of
was
setups.
obviously the IM absorption is also good. So maybe that can be used, but we routinely use it in an
Yeah, yeah, yeah. I mean,
not used to it in just
yeah,
IV book.
in big hospitals, I mean, it's possible to use IV. And when you
Yes,
are paying your attention for the delivery, you may not have time to give IV. There, you have to have someone assisting you
yes.
there.
Then that in that scenario, maybe IM will be.
Yes. If a patient is not responding adequately with carbetocin, which can happen, what additional nutrotonics you would be use or that can be used?
Um, in our settings, we mostly go for misoprostol.
Misoprostol, okay.
Yeah.
And root,
Um, per rectal, per vaginal, per
okay,
rectal.
okay. And how is the onset of action with misoprostol?
It is, I mean, if it is like, yeah, if it is going bleeding, then it is severe,
Oh,
then we use prostaglandins. If that
okay.
is, then we may go for misoprostol.
Oh,
If still we are anticipating and we want the no high risk still secondary prevention additional uterotonic needed, then we go for misoprostol.
side effects, nothing major, suppose of mis
For misoprostol,
yeah.
usually yes, well tolerated except for the
Ah,
hyperthermia and nausea, vomiting.
correct, correct,
Of course,
correct.
yes, the side effect profile is tolerable.
What are the advantage of carbetocin over these other uterotonics like oxytocin, misoprostol, carbeprosol, or methyl albumin?
Yeah, carbetocin definitely has a better hemodynamic safety profile. So it causes less increase in the blood pressure when compared to others, and of course, it is also this tolerability or the side effect profile is also good when compared to certain like carboprostol, methylprostol, ergometrin especially. They have a lot of nausea and vomiting and all these profile, which is less with carbetocin as we observe.
Have you seen those ADS type of effects with oxytocin, madam?
Of course, yeah, the hypernatremia and
Yeah,
the all this, of course, with the higher doses of oxytocin are
oxytocin,
definitely not there with carbetocin.
carbetocin. And cold chain not required is a major advantage in our country where there's power outage everywhere, including
Yes,
big cities.
absolutely. Room temperature, stability, all these are advantages.
Advantages. A single use, not requiring IV line. Again, an advantage in periphery, especially.
Especially peripheries,
Yeah.
yes, if they require a
Should carbetocin be kept as a reserve drug or should be used as a first line?
um, as I said, like we have been using this regularly for the past few
First
years
line, yes.
as a first line. So because I personally seen a lot of less, I mean, reduction in the PPH. At least the mild, moderate PPH level. I mean, the cases after the use of this carbetocin.
Carbetocin.
So even of course, maybe in the low resource setting patient situations where I don't know if the cost is a constraint for use in
Yeah, yeah, yeah.
them, but still in those high risk cases where they are anticipating,
PPH.
pH, they should be kept as a first line drug rather than a
Correct,
reserve.
correct, correct.
The prevention itself is pivotal in such situations.
Right.
So I think especially in our scenario, we use it as a almost as a first line
First
drug
line.
as of now.
That was
Uh,
5 years, almost 5 years you have been using.
yes, we've been using that.
Adverse effect or side effect profile vis-a-vis carbetocin. I mean, we have answered most of this question.
Yes, yes, I
Yes.
said.
Now your last, this last slide, your take on carbetocin for the audience.
With the you, I mean, we've been using for some time now, and we haven't found any extreme side effects or unpleasant effects as of now. So the tolerability and the safety as well, we haven't seen any hemodynamic or other disturbances following carbetocin administration, at least in most of the patients,
Yeah.
at least more than 90% of the patients. Of course, it is efficacious. We have used in many high risk patients where we had to, extremely high risk patients where we have resuscitated the patient and then operated on ventilator also, and very high risk for PPH also. We have seen this work better.
Okay.
So, in my practical knowledge, we have, I think it's efficacious as well as a good safety profile, and the tolerability is also
Good.
very good, and the
Yes.
complaints are very less.
Thank you, madam. Thank you so much, I mean, for sharing your experience. That's all
Absolutely.
what our doctors want, because what is documented and how our doctors use it here and experience is
Yes.
what is important. So
Yes, of
thanks
course.
once again for sharing your experience. And it is a big 5 years experience that you have been using.
Sure.
Thanks
Yes.
once again. So
Thank you
thank
so much.
you, everybody. Thank all the doctor for taking out time from their schedule and attending this webinar. Thanks, marketing team Hitro, for conceptualizing this webinar. Thank you, sales team, for coordination. And last but not the least, thank you, IT team, Jayant, for super backup support. Thanks, all of you. And thanks, madam, once again. Signing off. Thank you.
Thank you.
Thanks, Jayant.
Yes, thank you. Bye.
I'll leave now.
Yep.